You'll recall there was a time when stakeholders were resistant to anything but classroom training. While some still are, most now want effective alternatives to classroom training. How do we provide evidence-based education and training solutions that improve health systems? This presentation is about how we will bring solutions to the people rather than bringing people to the solution. We will discuss the benefits of implementing the education and training strategy, provide some practical examples, and discuss how the strategy will contribute to maintaining JPIGO's competitive edge. At the conclusion, I will share with you a wish list of commitments the Global Learning Office is seeking to continue moving in this strategic and innovative direction. JPIGO is great at education and training. We have unprecedented experience strengthening PSE systems. We are adept at implementing competency-based training. It is time to break the mold while embracing and honoring our history and ethos of innovations in learning. The heart of our strategy is a standards-driven approach to bring solutions to the people rather than people to the solution. In the past, governments and donors have looked to us for paper-based materials, development of expert trainers, and group-based training. Current demands are for effectiveness-demonstrated health and health systems level impact, greater penetration to where training is needed with a clear link to identified gaps. Efficiency, less costly, shorter, nimble. Sustainability, the ability to continue without external funding, embraced by health workers, requiring less time away from work. These are the three new pillars promoted by the current USAID HSS department: effectiveness, efficiency, and sustainability. With the goal of keeping our strategic direction in line with supporting evidence, JPIGO conducted 2 integrative reviews of the literature in 2011 and 2012. An integrative review means that while you grade and review articles, just as you do in a systematic review, you also can pull from other literature as well. It is a step up from a basic literature review, but not as rigorous as a systematic review. The report, The Health Impacts of Pre-Service Education, developed collaboratively between MER and GLO, analyzes evidence behind best educational practices, and results in a conceptual framework linking inputs to outputs and results. The conceptual model created is pictured here, and we will review it later in this presentation. Effective in-service training, techniques, timing, setting, and media analyzes those training practices that result in our desired training outcomes. Both technical reports are available on JLibrary. Manuscripts for in-service training have been accepted by the Human Resources for Health Journal, and the Pre-Service Education Report was published August 2013. Together, the findings from these reports were used to prepare our strategic approaches. Now is the time to take advantage of new and emerging technologies, simulation-based training such as Helping Mothers Survive, and QStream, an online spacing and testing platform created by a physician at Harvard, and simple solutions such as mobile mentoring. With USAID launching an Office of Health System Strengthening, complete with its own strategic framework, it is more important than ever to couch our education and training efforts in the context of health system strengthening. We do not only do curriculum strengthening or faculty development. We aim to strengthen pre-service systems. We do not only provide in-service training, we aim to strengthen systems of continuing health professional education and development. Using performance standards to identify gaps and drive interventions is more important than ever. In pre-service education, standards determine our priority interventions. In training, they provide a comparator for performance before and after an intervention. Standards are used now to determine gaps and support learning and performance. More than ever, we can make learning mobile, whether using smart or basic phones, netbooks, tablets, or computers or radio to bring continued health professional education to providers where and when they need it most. Now is the time to try new things and test them out. Educational techniques supported by the literature reviews included increased interaction and use of questions and feedback. Across multiple studies, the evidence was clear. Interactive techniques that require the learner to interact and respond to content results in better knowledge outcomes. No matter what media we use to deliver training, whether face-to-face or mobile, we will prioritize use of questions and feedback and interacting with the content. The new e-learning modules we produced with UNFPA illustrate this nicely by using questions and feedback as the primary technique, not just pushing content. The literature also supported less structure, less presentations, more simulation and practice and feedback. For example, the 2003 Clinical Training Skills course was 40% lecture and 60% practice. The new Training Skills 3-day course, used after learners complete ModCal for training skills, is 80% practice and 20% presentations. Helping Mothers Survive is the example that illustrates this nicely. The literature also found targeted, repetitive interventions result in better learning outcomes. You might call this low-dose, high-frequency. We want to move away from one-time, long trainings to shorter, more frequent exposures. Across multiple systematic reviews and some randomized control trials, repetitive resulted in better learning outcomes. Helping Mothers Survive illustrates this nicely and is designed for more frequent, shorter interventions. QStream has 8 to 10 well-constructed randomized control trials that demonstrate the effectiveness of the use of spaced and repeated questions. QStream has recently become privatized and is no longer free and open to the public. However, JPIGO has maintained a QStream account and is in the process of developing courses for HIV and infectious disease technical updates. The evidence on setting was limited, but indicates workplace or simulation center-based learning is important for skill development. Rather than bringing 25 people to a classroom, we will bring the classroom to them via netbook, tablet, smart or dumb phone, or a mentor. We are doing this through QStream, Helping Mothers Survive, and with facility-based mentoring. We are providing facility and district health management team-based mentors with Android tablets loaded with performance standards linked to the resources needed to support mentoring. This was done in collaboration with JPIGO's Health Systems Development Unit in Malawi. We know from the literature that media should be selected based on their potential to support effective educational techniques and efficiency of instruction. We will move from print-based to greater use of multimedia. Known for JPIGO's print-based materials, the 21st Century JPIGO Learning Resource Package will have less text, great use of graphics, and video. This is important for expanding into frontline health worker cadres, where low literacy is a key issue. We will prioritize delivery mechanisms that increase learning efficiencies. Moving into M and e-learning is key to increasing reach and possible efficiencies of scale. This includes exploring the role of massive online open courses, or MOOCs, which can be offered through and in partnership with Johns Hopkins University. To summarize recommendations related to the 4 aspects of training included in the strategy. For technique, increase interaction and use of questions and feedback. Use less lecture, fewer presentations, more simulation with practice and feedback. For frequency, low dose, high frequency is preferable to one-off interventions. For setting, prioritize the workplace or a workplace-like setting for interventions. Bring the classroom to the people. For media, move from print-based to greater use of multimedia. It is important not to let the media drive a learning intervention. For example, using any form of computer in a school or facility without reliable internet and electricity is likely not the best learning solution. But do prioritize feasible delivery mechanisms that increase learning efficiencies. Ask what people already use to obtain clinical knowledge updates, such as text messages, calls, perhaps radio, or perhaps internet accessed through personal cell phones. No organization in the NGO field has as much pre-service experience as JPIGO. Over the past 40 years, we have implemented more than 120 USAID-funded pre-service education programs in more than 38 countries: Afghanistan, India, Tanzania, Pakistan, Ethiopia, Liberia, Mozambique, Botswana, to name a few. What did we traditionally do? We focused on inserting in-service type supplements into curriculum, typically including targeted teacher training, preceptor development, and skills lab support. As USAID and other donors move to a heavier focus on standards-driven health system strengthening, our experience in impacting educational systems and health workforce development gives us a competitive advantage. But we have to move forward in different ways to keep our advantage. So where are we going? We want you to take a systems approach for pre-service education consistent with new USAID focus on HSS. This is also consistent with the increased global and U.S. government focus on regulation, which is part of Office of Global AIDS Coordination's new HRH strategy. A systems focus helps a country's government invest wisely and ensures inputs support the outcomes desired. Interventions need to be standards-driven, beginning with advocating for strong educational standards. There are many existing international standards that can be used if national standards do not exist and need to be developed. Isolated interventions to improve provider knowledge are less likely to be effective and are difficult to link to desired outcomes of improved performance at a larger scale. Educational efforts should include strengthening professional associations, as we have done in Afghanistan and Indonesia and several other countries. As USAID and other donors move to a heavier focus on HSS, our experience in impacting educational systems and health workforce development gives us a competitive advantage that we plan to leverage. We mentioned that our literature review was used to develop a conceptual model. Let's look at that model now and how it can help you plan and implement programs. An integrative review of the literature on pre-service education was used to create this conceptual model, linking educational inputs to the desired outcomes. The educational inputs on the left-hand side of the model provide JPIGO with a structure for organizing our needs, assessment tools, our educational standards, and our program activities. We have a draft activity matrix available on my JPIGO GLO technical page for pre-service education programs that is organized by these 5 inputs. Here are our current priorities and strategic approaches for each of these inputs. Students, making sure that the right students are selected and then supported in order to maximize their opportunity to learn. Teachers, tutors, and preceptors. All health workers responsible for facilitating student learning must be able to effectively shape the learning environment, teach, and assess students. Infrastructure and management must be strengthened in a manner consistent with target competencies and contemporary teaching practices. Computer labs containing electronic resources and e-learning modules will be more important than libraries where feasible. Skills labs will be more important than classrooms. Satellite learning centers established in health facilities where students learn will provide opportunities for students to study closer to their communities. Curriculum will be guided by internationally vetted competencies and health system needs. Task analysis will continue to link curriculum inputs to those tasks most essential to new graduates immediately upon deployment. Clinical practice sites will gain primary rather than secondary importance in pre-service education. Our strategic direction will also account for factors that influence the operation and sustainability of educational systems. Influencing factors may include health systems policies, existing human resources needed to support education, current competence or performance within the health system, financial resources needed to educate students, deployment policies, and regulation, the ability to accredit the quality of education and certify the competency of graduates at the time of deployment stands out as an influencing factor of special significance. When thinking about a systems approach to pre-service education strengthening, there is a need to advocate for solutions that address all components of the model, such as better student recruitment and support, teacher or faculty development, stronger infrastructure, spending more time and attention improving clinical practice, including clinical site strengthening and preceptor development. Clinical practice sites and preceptors must become an integral part of the education system rather than an annoying problem. Stronger competency-based curriculum, and in particular better use of assessment to improve learning outcomes, including knowledge and skills assessments. This is also something that we are doing in many of our programs, and encourage you to use the model to identify how you can address all the different inputs. Even if a funded project is narrowly focused, consideration of all parts of the model can strengthen strategies by identifying the effect on and by influencing factors. Standards-driven. Always use educational standards, whether they exist or if they need to be created, to strengthen the educational system and identify what activities and interventions you will program. Take education to the front line. Look for opportunities to recruit and educate locally, preparing community health centers and facilities to provide clinical practice. Use a blended learning approach, combining a mix of methods, including structured self-study, whether via paper, computer, or mobile devices, with local clinical placement. Community health centers and facilities can be prepared as satellite learning centers for existing universities. This will improve chances of health worker retention and provide opportunities for those that might otherwise not get them, particularly faculty and preceptors. While many of our programs are focused on in-service training, recently more are asking for continued health professional education or development systems linked to relicensure. This is a systems approach to ensuring a competent workforce is available within the community and facilities that support them. We want to shift from donor-driven training to government and professionally driven continued professional development in countries where the ministry asks for and wants this type of support, or where we can identify other funds to support it. Look for opportunities to link in-service training to continued professional development systems and processes. Let performance standards guide training interventions provided. Using performance standards to assess which gaps need training and which do not allows us to target training and make it more efficient, so training can be provided as part of continued quality assurance. Then you can prioritize providing training for those skills most important for maintaining competency, or task shifting or sharing. Look for ways to bring solutions to the front line. Whether using interactive radio, smart or simple mobile phones, computers, tablets, or netbooks, more than ever we can bring learning opportunities to the workplace so people can learn where and when needed. Help ministries of health and professional associations think outside the box as well as accredit and count those learning opportunities toward continued health professional development. Our strategy is complementary to existing approaches, but seeks to address effectiveness, efficiency, and sustainability to lead to transformative change in how we prepare and support the health workforce. We thank you for your continuous support of education and training efforts and your support of healthcare workers in job performance, as well as, of course, the patients that they serve. Please take the time to review both technical reports available on ReproLine Plus. Do you have any programs or ongoing work that we could help you with? Any opportunities to use some of these approaches? Call us or email glo@jpigo.org. Please contact GLO early, involve us in your brainstorming, program planning, and new proposal development. We hope to hear from you soon.